So we are going to learn about acute mesenteric ischemia. So classification, it can be classified based on the cause and based on which segment of bowel is involved. So based on the cause, it can be occlusive type and non-occlusive type. Occlusive type itself, it can be arterial and venous. Arterial itself, it can be thrombotic or embolic. So the most common is in embolic type of arterial occlusive cause of acute mesenteric ischemia. And based on the location, it can involve small bowel ischemia or large bowel ischemia, that is ischemic colitis. But most common is involvement of the superior mesenteric artery, and the cause is occlusive due to embolus. So what are the clinical features? Patient will be having severe abdominal pain out of proportion to the examination findings. Associated with that, patient can have diarrhea, vomiting, occult bleeding. So even if you are giving analgesics, patient will be still complaining of pain. Now on the late stage, what happens? The patient can present with features of peritonitis, shock and metabolic acidosis. So what is the role of ultrasound here is, we could see the proximal vessels, the celiac trunk and superior mesenteric artery, and if there is any occlusion. Now in the late stage of the disease, when there is intramural gas and portal vein gas, that can also be evident. But at the same time, there are some limitations, that is, if there is occlusion in the proximal segment of the superior mesenteric artery, then we can identify. But if it is if there is occlusion but it is in the distal segments, or if it is a non-occlusive cause, then in such cases there are limitations of ultrasound. Now when we compare the causes, arterial embolism, we know that is the most common, versus arterial thrombosis versus venous thrombosis versus non-occlusive mesenteric ischemia. So a patient is having an acute presentation in the background of some heart disease, atrial fibrillation, endocarditis, or a recent myocardial infarction. Is that a history of embolic cause of arterial occlusion, SMA occlusion. At the same time, a patient can present with acute on chronic, especially elderly, in the background of atherosclerosis, then that is thrombotic type. Now venous thrombosis is mostly a subacute presentation in patients who are having hypocoagulable conditions like factor V Leiden mutation, antiphospholipid antibody syndrome, or who are consuming OCP, then pancreatitis, like that. Complication of pancreatitis. Then non-occlusive mesenteric ischemia means there is global hypoperfusion to the entire segments of bowel. So it could be acute or subacute in a patient with shock or who is having hypoperfusion. It can be due to shock, multi-organ dysfunction, or there can be hemorrhage. Maybe he's on some vasopressors, vasoconstrictors. Now, which segment of bowel is involved? So, we have to look at three things. One is the bowel, one is the vessel, and nearby organs. These three things we have to check in imaging. The investigation of choice is CT angiography. Now in case of an embolism, mostly it is involving middle or distal SMA, and it is involving short segment of the bowel. Whereas in case of thrombosis, mostly it is involving the proximal SMA, and there can be an extensive long segment of bowel involvement. In venous thrombosis, it's mostly along the venous territories, could be discontinuous. In non-occlusive, it is global hypoperfusion, so it will be patchy, long segment of bowel will be involved, and it is not based on any vascular territories. Now we have to look at the bowel wall thickness, what is the attenuation, and what happens after contrast and bowel dilatation. So in case of arterial hypoperfusion, the bowel will be paper thin. It is because the intramural blood vessels have decreased blood flow, so the muscular tone is decreasing. As a result, the bowel is getting paper thin in case of arterial hypoperfusion. And when you are looking into the density in a plain CT, we are expecting hypodensity. But at the same time, if there is any intramural hemorrhage, in such cases there can be hyperdensity. But after contrast, we are expecting hypo enhancement. But can we see hyper enhancement in arterial hypoperfusion? Yes. If there is reperfusion, there can be hyper enhancement, but otherwise it is hypo enhancement. Now in case of venous thrombosis, bowel wall. Now in case of, so this is in case of arterial embolism. If there is thrombotic type, so the bowel characters remain same irrespective of whether it is thrombotic or embolic. It's mainly based on whether it is arterial or venous. So arterial it's same features, whereas in the case of venous, there will be bowel wall thickening. Bowel wall is thickened. There is arterial perfusion but venous stasis. So venous congestion will be there. As a result, there will be leakage, increased plasma permeability, so that there will be leakage of this RBCs and plasma proteins, exudates, so that there will be submucosal edema. So that is causing bowel wall thickening. And attenuation, it can be either hypodensity. If there is any hemorrhage, there can be hyperdensity. Enhancement, we are expecting hyper enhancement. So what happens is this, there is submucosal edema with hyper enhancement of this mucosa and muscularis propria. As a result, this gives an appearance of halo sign or target sign. And bowel dilatation is prominent in venous thrombosis. Non-occlusive mesenteric ischemia is just like arterial only. When you look into the vessels, in case of an embolus, SMA embolus, we could find it mostly in the middle or distal segment of the SMA, whereas in case of the thrombotic, mostly it is involving the proximal part of SMA. In venous thrombosis, when you look into the veins in SMV or IMV, you could see the filling defect. And non-occlusive mesenteric ischemia, you could not find any filling defects. There is no occlusion. You might find some bead-like appearance of these vessels. Now looking to the other organs, in case of embolic cause, there could be infarct involving the other organs like spleen and kidney. Now in thrombotic type, there could be extensive atherosclerosis involving other vessels also. In venous thrombosis, we might expect, other than superior mesenteric vein, we could also expect thrombosis in splenic vein and portal vein. In non-occlusive mesenteric ischemia, the constellation of signs what we get in case of a hypoperfusion, global hypoperfusion, that is collapsed IVC, there could be hyperenhancing adrenals and reduced aortic caliber. So in case of a embolic type, you could have an endovascular treatment, thrombolysis, thrombectomy. So it all depends upon the stage the patient is in, the severity. If it is in the late stage with features of peritonitis, maybe laparotomy is needed. In case of embolic and also in case of thrombotic, arterial cause, the same management. In case of venous, mostly we do anticoagulation, and in case of non-occlusive mesenteric ischemia, especially we have to avoid some giving other vasoconstrictors, and we give intra-arterial dilators like nitroglycerin and papaverine. This picture we could see arterial occlusion, embolic cause, you could see the emboli mostly in the mid and distal segment, thrombosis we are seeing mostly in the proximal segment of the SMA. So emboli it is in the mid and distal segment with involvement of the short segment of the bowel. Whereas in case of the thrombotic type, it is mostly involving the proximal segment of the SMA, and it could have an extensive involvement of the bowel. In non-occlusive mesenteric ischemia, you are not seeing any occlusion. There is string of bead-like appearance of the vessels, and the bowel involvement is like patchy. It could be long segment, irrespective of some vascular territories. You could see the normal bowel. Now, what happens in case of a hypoperfusion? So, it is getting paper thin because of the loss of the muscular tone. It is getting paper thin in arterial cause, whereas in venous cause it is getting congestion, and in venous occlusion you could see a venous clot in the venous territory. The bowel is getting involved, and what happens to bowel is halo sign or target sign. This is showing hypoattenuating and also paper thin bowel walls, which we are getting in arterial cause. We can see the thrombus in the filling defect in the proximal part of the SMA. Here this is the embolic cause. We are getting infarct in the right kidney, and the mid or distal segment of the SMA is there is filling defect. What are the complications it can occur? So because of the hypoperfusion there can be infarction, necrosis, and later what happens is the bacteria which is inside the lumen, they can translocate and proliferate into the wall, intramural side, and they can produce gas within the wall, that is causing pneumatosis intestinalis. The gas, then they can enter into the mesenteric vessels, they can reach the portal vein, that is portal vein gas, pneumatosis portalis, and the later stage patient can have there can be perforation, peritonitis with features of peritonitis. So here the proximal SMA there is thrombus, and the bowel walls we can see the pneumatosis intestinalis of bowel walls. Here also pneumatosis intestinalis, and we can see portal vein gas and the necrosed bowel picture. So the clinical picture of this patient having such severe abdominal pain, think about small bowel obstruction, it could be strangulating or closed loop obstruction, pancreatitis, peptic ulcer, appendicitis, diverticulitis, renal colic or ruptured abdominal aortic aneurysm. All the acute abdomen causes comes into our mind, and even the CT findings what we are getting also can have mimickers. Like when we are getting occlusion of the vessels, we are seeing in embolic, whether it is embolic, thrombotic or venous, so that can happen in vasculitis. Bowel wall thickening can happen in otherwise in inflammatory, infectious or malignant process. Bowel wall enhancement, it can be in IBD, radiation graft versus host disease. Bowel dilatation we can also see in ileus and the pseudo obstruction. Then pneumatosis and portal venous gas, that can also be a benign finding in case of asthma, emphysema, or if there is any intra-abdominal procedures done, then it could be a benign finding. Thank you.